First of all, brain metastases are a major problem in cancer. About 25% of patients with cancer develop brain metastases, and this represents about 400,000 patients per year in the United States by some estimates. To understand the scope of that, there are more patients diagnosed with brain metastases than there are with breast cancer. About 200 to 250,000 patients are diagnosed with breast cancer, and the same for lung cancer. So it's a major problem with an unmet medical need with inadequate available therapies. The study by Dr. Brown was conducted in a manner funded by the National Cancer Institute through the Alliance Clinical Trials Network. And that trial was a randomized study which treated patients who had 1 to 3 brain metastases that were smaller than 3 centimeters each, with either stereotactic radiosurgery to each lesion followed by whole brain radiotherapy, or stereotactic radiosurgery without whole brain radiotherapy. And they had 2 main conclusions. First, that whole brain radiotherapy did not prolong survival, and second, that patients who received whole brain radiotherapy had worse memory than the patients who had worse neurocognitive function than the patients who were observed. But I think those conclusions need to be taken in the context of other trials in this disease. So first of all, the study was not designed to assess survival as an endpoint. The study was not powered for that question, and other studies have clearly demonstrated that survival is prolonged in a subset of patients who receive whole brain radiotherapy. And one of the keys that we need to understand as a field is which patients are likely to benefit in terms of survival from whole brain radiotherapy. So I think rather than a blanket statement that whole brain radiotherapy should not be used, I think the treatment needs to be individualized, which is a form of precision medicine. Second, the whole brain radiotherapy did injure neurocognition, and that is a well-established observation that's occurred in other studies. This trial found neurocognition was worse at 3 months, and it also suggested that neurocognition was worse at 12 months among the patients who received whole brain radiotherapy. However, the number of patients that were evaluated 12 months after whole brain radiotherapy was relatively small. It was about 30 to 35 patients. Other studies have actually shown that 12 months after whole brain radiotherapy, patients have stability or even improvement in their neurocognition. And that is because in comparison to patients who do not have whole brain radiotherapy clearly reduces the risk of recurrent brain metastases. And so other studies have found that the recurrence of the brain metastases is actually worse for neurocognition than the whole brain radiotherapy itself. But both of these are bad options. Both whole brain radiotherapy and recurrent brain metastases are bad for the brain, and we need better, different alternatives. And many of those alternatives are now under evaluation. So one method using a modern technique to bend the radiation beam is called hippocampal avoidance whole brain radiotherapy. So this spares the structure of the brain called the hippocampus, which is very intimately involved in memory. And so this method seems to allow whole brain radiotherapy to be given, yet not have the injurious effects on cognition, and in particular on memory, as giving traditional whole brain radiotherapy. And that will be evaluated further through a randomized trial conducted by the NRG Clinical Trials Network. In addition, drugs that are used in dementia, such as memantine, when combined with whole brain radiotherapy, seem to ameliorate some of the effects of whole brain radiotherapy on memory, and that will also be studied through a follow-up trial, again conducted by the NRG, which will combine hippocampal avoidance whole brain radiotherapy and memantine. Finally, many other chemotherapy drugs that are used for patients with cancer seem to control not only the extracranial disease, but also the intracranial disease. Immunotherapy, for example, is a big topic at this year's meeting, and immunotherapy in melanoma appears to control not only disease in the body, but also disease in the brain. And so I think options for patients are expanding and may allow us to defer whole brain radiotherapy or modulate its effects.